All right, so this is going to be our fifth visit, treating the same demo, our same volunteer, for the fifth time for her DRA. And just as a reminder, when she came in to see us, it was a 3.5 split above the belly button, 3.5 split at the belly button, and then a 3.5 split below the belly button. After her fourth visit of just treating the jejunal or the small intestines with visceral manipulation, the upper one, 3.5, went to a 2. The 3.5 at the belly button went to a 1, which is normal, by the way. 1 to 1.5, very normal because the umbilical cord comes out here, so that's a normal split. And then below went to a 0. Now again, she has a suprapubic scar here, so a C-section scar here. So sometimes that lower one takes a little bit of time to resolve with that. Sometimes we have to do some scar work, but with her, after the last visit, it was a 0. We'll see if it stayed there or not. I'm not quite sure if it did or it didn't, okay? So we've been having a little trouble with this 2-finger width split up here. Again, it's better than 3.5 for sure. 3.5 to 0, this is pretty much resolved. We'll see where it's at today. 3.5 to 1, pretty much resolved. It goes to 1.5. I'm not too worried about it either. But this one has been probably since, I think it might be the second visit, I'm not quite sure. It's went from a 3.5 to 2, and it's just kind of stayed at a 2. So some of the things that we're finding is instead of treating the jejunal like we did for 4 visits, we would do that, and then if this upper one above the belly button was still there and not resolved, we'd move on to treating the first leg of the duodenum or the duodenum, depending on where you're at in the world. So let's go ahead and check and kind of see where she's at. I haven't checked her yet. And so above the belly button, again, my measurements, I use my ring finger in the belly button where my index finger comes. That's our first measurement space. Go ahead and lift your head up for me. Keep going. Yep, she's still at a 2. And then back down. And then we're going to go to the belly button. Hold on. And then come on up. Good. That's still a 1. That feels pretty good. And then back down. And then again, index finger in the belly button where my ring finger comes, that's my measurement space. And then go ahead and come on up. This is gone. Okay, so that's great. That stayed. So that's still at a 0. That's still at a 1. This is pretty stable. When she came in today, she was telling me that she was coughing pretty heavily before she came in. And again, it's been about 4 weeks since our last session. Usually I do every 3 weeks, but we had the holidays, so we we missed a week, so it's been 4 weeks. Excessive coughing usually puts a lot of strain on this, and it really did not reverse. Basically, we're right where we were when we ended at the 4th visit. And again, we're still stuck with this 2-finger width split here. So let me show you a little bit of anatomy and kind of what we think is happening here with the duodenum. So, okay. So we talked a little bit about the balloon, right, and the parietal peritoneum. So if you can think of this sheet as the back of the balloon, think of a water balloon. Right? This purple thing here is the duodenum or the duodenum. Okay? So this is the back of the balloon here, the posterior parietal peritoneum. This is the duodenum or the duodenum, again, depending on where you come from, depends on how you say that word. Your stomach is inside the balloon. Okay? Your stomach is inside the balloon, and your stomach hooks up with the duodenum or the duodenum. Okay? Just kind of hooks up like that. So the duodenum is the next tube that your food would go through after your stomach has churned it and broke it down. It kind of moves into the duodenum here. And we, and the Brawl Institute, and those of us who do the visceral manipulation, we label these as leg 1 here, leg 2 kind of coming vertical here, leg 3 is about belly button location, and then leg 4 here, okay? And so we're inside the balloon with the stomach. We're inside the balloon with the first leg of the duodenum. And then you'll see the 4th leg of the duodenum, we're inside the balloon with the 4th leg. And the reason being is that fun jejunal comes in and it connects right there. Okay, so your small intestines connect to this leg 4 of the duodenum. And then it starts with about 21 feet of small intestines. So those small intestines are inside the balloon. So So all of that's inside the balloon. The front of the balloon, if we put this down as the front of the balloon, would be over top of all of that, okay? Your liver would be inside the balloon, the gallbladder. There's a lot of things inside the balloon, and there's like a fluid in there. There's a serous fluid, okay? So think of it as a water balloon. And that serous fluid is there so these organs can slide and glide and move and do all that stuff, okay? So if we go ahead and we peel away the front of the balloon, and then we get rid of the small intestines, because we've already treated this. And just to give you an idea of the anatomy, that root that we worked on, that kind of started right about here at DJ, okay? And there's an opening in the posterior parietal peritoneum that kind of runs down to the ileocecal valve, right through here, so that all those mesenteric arteries and veins that are behind the balloon, what we call retroperitoneal, can get out and feed the small intestines that are inside the balloon. Okay, so if we get rid of that, we've already treated that. And then we get rid of the stomach, just so we have less to look at. So we're looking at the back side of the balloon. So again, we cut off the front side of the balloon. Think of it a water balloon. We're looking like on the inside of it. You can see leg 1 here is inside the balloon because it's got to attach to the stomach. Leg 4 is inside the balloon because it's got to attach to the small intestines. But leg 2 and leg 3 are retroperitoneal, meaning they're behind the balloon, okay? They're behind the balloon. They don't slide and glide so much. The other things that are behind the balloon is like the pancreas and the kidneys. All those things are behind the balloon, like right behind this. You know, we could put all of them right behind that. And those structures don't move that much because they don't have a lot of fluid around them, okay? So when we have any stress or strain, like pregnancy, to the parietal peritoneum, what we think is happening is at these little openings, and the openings to the root of the jejunal-ileum here, the opening here for D1, it gets some stress and strain because this is not going to move and this is not going to move. So leg 2 and leg 3 are not going to move. They're pretty fixed. And so the balloon is going to get tugged on. It's going to move. The balloon's going to move around, and it's going to create a restriction here. So what we're finding with a lot of our patients is if the DRA, especially this upper one, doesn't completely close with 4 visits, just 4 visits of visceral manipulation to the jejunal-ileum, we move on to leg 1 of the duodenum. And a lot of times what we're finding is this part of the parietal peritoneum where D1 kind of pokes its head through, the inferior aspect of it is where the restriction is at. And we've been seeing a lot of patients with this, and multiple therapists are finding the same thing, so it's not just me. And so what we get with the listening, and in the bra world, we kind of talk about local listening where we get pulled into a structure. And if those of you that are not medical people out there, if you can just think of this structure being upset with this restriction right here, and it has a lasso, and when my hand gets near it, it lassos my hand and kind of pulls me into the restriction and says, hey, I've got a problem here, I really need some help. Now, what's really happening is all the connective tissue and fascia and everything are kind of getting pulled into this spot, so you'll feel that with your hands. So already with this demo, she has a listening into this first leg of the duodenum, and then if we fascia load it, we'll get a listening that goes it kind of loops around just underneath the tube and into the posterior parietal peritoneum. So her listening specifically is the listening we're getting on almost all of our patients here that have this split in the upper, above the belly button, is between the posterior parietal peritoneum that's just inferior to D1, okay? So what we're gonna do with this technique is this. I'll show you the listening in a minute, but literally, we're just gonna get a hold of the tube. So we're gonna get a hold of the tube, the top part, the bottom part, thumb and fingers, and we're gonna squeeze the tube in on itself. Okay, so we're just going to squeeze it in on itself, which will create a little bit of proprioceptive input here, like a little bit of stress, a little bit of strain. Body's not going to like that. So what's going to happen is the tube will roll inferior into the posterior parietal peritoneum here, and it'll probably shear around and do whatever it needs to do to release this, okay? Or at least start that process. Again, it takes about 3 weeks for it to complete, and then it'll relax, and then we'll squeeze, and we'll do it again, about 3 times. And then we'll see what happens, but we're getting some success with that, okay? So leg 1 is what we're gonna treat, and then the inferior aspect where it kind of pokes its head through posterior parietal peritoneum, okay? So that's where we're headed. Okay, so for listening, if you had a bowl with saran wrap on it, and and you put your hand on that saran wrap, and you close your eyes, and I came around and I pinched the saran wrap, you would feel that. You wouldn't have to open your eyes. And why? Because you would feel the pull through the saran wrap, right? Because all the saran wrap is getting pinched underneath my fingers. So same thing in the body. The body will hug and protect restrictions. So there'll be multiple connective tissues and fascias and all kinds of stuff that are guarding and protecting something. And so with our hands, we literally physically get pulled into it. And those are called listenings. Okay, so we let the body tell us where to treat typically. And so I'm using the palm of my hand here, and right there I get a listening. And it takes me in, and I'm pretty sure this is D1 of the duodenum. I can inhibit that, I can think about it, and the listening comes back right away. Okay, that tells me, yep, you're on the right structure. And then if I do an extended listening, meaning I get my listening into D1, and I just kind of fascial load D1, it'll tell me exactly where the problem is. And I'm literally rolling over that tube like I showed you a second ago to the inferior aspect of the tube at the posterior parietal peritoneum. And if I think posterior parietal peritoneum and I touch it with my finger from my left hand, it comes back. I know that's what I need to treat right now. Okay, so the way we're going to treat it is this. We're going to find D1. So I'm going to find her xiphoid process. Okay, and take my fingers. It doesn't matter which fingers you use, but don't use fingertips. That's very uncomfortable. Use finger pads. I'm going to sink in just a little bit so I'm not just on her skin. I have her knees bent on a bolster, by the way, so I don't have to fight her abdominals. And I'm going to slide down with these fingers until I feel a shelf. Right there is her shelf. Okay? So that's the top of the tube. Okay, that's the top of the tube. And then I can bring my thumbs to my fingers and I can feel the tube. It feels like a garden hose, and I can just walk over the tube until I fall into a hole. Okay, so again, top of the tube is here with my fingers. My thumbs will come to my finger pads, and it'll be garden hose feel under them. Garden hose, garden hose, garden hose. Oop, fell into a soft spot. Okay. So this is her D1. Now her listening, I want to be very specific, is right there. Okay, it's right there. So I want to get my thumbs right where that listening goes to with that posterior parietal peritoneum. This is tight up here. She probably can feel that. And that's D1. So be careful. The pancreas is in here. It kind of lays just like this, kind of deep. And the duodenum wraps around the head of the pancreas. So don't be poking really deep in this area. Okay, so be careful with your thumbs. And here we go. Thumbs are on the lower part of the tube of D1. Fingers are on the upper part of the tube of D1. And we're just going to squeeze the tube in on itself. Thumbs and fingers come together. I'm visualizing it with the posterior parietal peritoneum. And here she goes. The tube is rolling towards her belly button, if that makes sense. So it's kind of like an anterior roll. And there's some gurgling happening. That's usually a good sign. There's a little shear off to her left. A little shear off to her right under my thumb. So her body knows how to release this better than I do. So we're just creating a little bit of proprioceptive input, a little bit of tension. And then the body does the rest. And now she's slowly coming back out of that, meaning she's coming back to the resting spot of D1. And right there, she stopped. Okay. So I'm going to give it a second. And I'm going to move my fingers so I can just show you how to find it again, just so you have it. You wouldn't have to remove your fingers and thumbs. You could leave them there. You just stop engaging it. So again, xiphoid process, guys. Finger pads underneath it. Sink in. Slide down until you feel the tube. Okay, right there's the top of the tube. It's just a garden hose feel. And then my thumbs are going to walk over, garden hose, garden hose, garden hose, sink into like a little hole. So it's like a lot of tone, lot of tone, lot of tone, soft. Okay, so hard, 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 soft. Okay, and now I know I'm on the other side of the tube. You could probably also just look for the red spots on the skin and get the same thing. So my fingers are on the top of the tube, my thumbs are on the bottom of the tube. Again, I know her restriction spot is a little to the left of the belly button there, and so I move my thumbs over just a smidge for that. And here we go. Thumbs and fingers are going to sink towards each other like I'm squeezing the tube. Here we go. And here's her response. The tube is rolling anterior, meaning it's kind of rolling towards her belly button, meaning it's kind of rolling into that posterior parietal peritoneum where my thumbs are at. And now it's rolling back to midline. This is usually the release we get, and then a lot of times it'll shear to the left or to the right. This is pretty typical of what we're finding at our clinic. Now I'm going to relax. Now this is how I typically would treat. I wouldn't take my fingers and thumbs completely off. I would just kind of relax in this position, give it a second or two, and we're going to go again. Okay, find the top of the tube. Bottom's right there. And here we go again. I'm visualizing in my brain. My eyes are closed. What does D1 look like? What does that posterior parietal peritoneum look like? We've got a pulse right now that we didn't have a minute ago. That's usually a good sign as well. I'm squeezing the tube in on itself. It's rolling anterior, meaning it's rolling into that restriction on the posterior parietal peritoneum that was just below the tube. And now my thumbs are shearing. They're shearing to her right. They're shearing to the left. They're shearing to the right. They're shearing to the left. And right there, they just stopped. Okay. That was a good release. I'll wait a second or two. That might have been it. So we'll see. We'll go one more and we'll just see if I get any reaction whatsoever. We think of these loads as telephone calls. And if the body picks up, great. You're doing great and you've got some movement going. If it doesn't pick up, you either need to change what you're doing or you're done. Okay, so we'll see if they pick up this telephone call here. We're going to squeeze the tube in on itself again. I'm getting a really big pulse, which is awesome. And just see if we get anything besides gurgling. No, it's pretty calm. Nothing is happening. Okay, so that's the technique. There's other ways to treat D1, but we're finding with the DRA and its specificity with the posterior parietal peritoneum, that restriction, just squeezing it and letting it roll into it seems to be the best case scenario. So again, just kind of squeezing this and allowing it to kind of roll anterior like this into it is better than one of the techniques we do is we stretch it in a seated position, but then that stretches it like this. We don't want that. We're kind of looking at a restriction here for those of you that do this work. Okay, so I'm going to come back. I'm going to see, do I have my listening, meaning is D1 still going to lasso me into it and say, hey, I still need some help here? Or did I give it enough proprioceptive input that it's going to make some changes? And I'm even doing a fascial load here, trying to wake her system up to like pull me in, and it's not. So it's pretty quiet right now. I'm not getting pulled into D1. So I don't know if things have changed or not. Again, it takes about 3 weeks to take hold. Visceral manipulation, we just start something through proprioceptive input or mechanoreceptors. The body takes over and makes changes, which is why some of the times when she came back, her numbers were better than they were at the end of the treatment. So we're not attached to what this looks like. It could still be 2 finger widths, and I would be totally fine with that. If it's less, I'm overly thrilled as well. So don't be attached to your numbers because, again, things happen when they get off the table. Okay, so we'll see. I'm not interested in belly button and below because these are pretty much resolved now. So all I'm interested in is how is this upper one doing? So again, ring finger in the belly button. Okay, and it's interesting to see the red spots and kind of where I'm going. It's almost the exact same spot that I just treated, which is interesting. Okay, so here we go. Go ahead and lift your head up. Dude, that's just super fun, isn't it? Okay, so guys, I'm just going to keep doing this so you know I'm not playing and I'm not faking this. This is 1 finger width now. That's a muscle belly, and she could tell you I'm pushing on it pretty hard. Okay, she just shook her head yes. And now that's a muscle belly right there. This is 1 finger width, and it's more shallow than it was before. Go ahead and put your head down. So it went from 2 finger widths in a pretty nice depth to 1 finger width in a little bit more shallow in that tiny little treatment. Okay, so, and again, hopefully she'll come back in 3 weeks. We'll see what happens with this in 3 weeks or 4 weeks, whatever we can do schedule-wise. And maybe it'll be completely resolved. If not, we'll treat it again.